Hey everyone, this is Dr. Chris Fox from the Student Physical Therapist. For this month's Insider Access video, what I wanted to go over was some research that's a little older pertaining to managing cervicogenic headaches and manual therapy. So for those of you familiar with some of the evidence-based practice and the modules that we've done before, cervicogenic headaches typically has a unilateral presentation and is tested with the flexion rotation test of the AA joint, looking for a difference of like 10 to 15 degrees of rotation being statistically significant for classifying the patient. So this study here, upper cervical and upper thoracic manipulation versus mobilization and exercise in patients with cervicogenic headache, a multi-center randomized clinical trial. The first thing we want to make sure we check here is how much does this pertain to our patients? So we could see CH, cervicogenic headaches. That's kind of what they're targeting as their audience, or not their audience, their subject for applying to the patients that we may see. But we want to know how they classify cervicogenic headache. And so coming down here to the background, we can see dominant features of cervicogenic headache usually include unilaterally of head pain without side shifts, so it's not switching back and forth, elicitation of pain with external pressure over the ipsilateral upper neck, limited cervical range of motion. Now, it doesn't say specifically the flexion rotation test, but it is along those lines. And then triggering attacks by various awkward or sustained neck movements. So some lines up with it, some not necessarily. They didn't do any deep neck flexor endurance testing or CCFT, the craniocervical flexion test, but this likely will fall into that classification. So there's research in various places where they talk about mobilization being just as effective as manipulation. This study is trying to claim that manipulation is more effective. So when we look at the participants, I believe there were over 100 participants. Let's see. So therefore, to be included, they needed unilaterality of head pain without side shifts, starting in the upper posterior neck and occipital region, spreading to the oculofrontotemporal area of the symptomatic side. Pain had to be triggered by neck movement and or sustained awkward position. A reduced range of motion in the cervical spine, less than or equal to 32 degrees of passive rotation on the flexion rotation test. So they did use it, but they didn't necessarily look at a difference. They just wanted a loss of motion. So that is a little bit different than what some of the research has said. Pain elicited by external pressure over at least one of the upper cervical joints, and moderate to severe non-throbbing and non-lancinating pain. Have to have a headache frequency of at least 1 per week for a minimum of 3 months. Okay, so that kind of narrows it down between the ages of 18 and 65. I think they're trying to account for people being too young, and then also people that are a little too old, maybe having too much degeneration in their neck. If they were suffering from other sorts of headaches like migraines, tension type headache, cluster headaches, bilateral headaches, or red flags, they were excluded, which is probably a smart call because the research does not say that migraines or other types of headaches respond very well to physical therapy. All right. So the treating therapists, 12 of them, about 10 years average clinical experience, and had some postgraduate certification training in manual therapy, probably through a specific group. So they're using the neck pain medical screening questionnaire, the NDI, okay, headache frequency, headache duration. So they are trying to make it specific for headaches as well. That's very good. Numeric pain rating scale, which is not terribly effective. NDI, global rating of change, headache frequency. Okay, so they definitely are. Oh, medication intake. So they're looking at a lot of different factors there. Patients return 1 week, 4 week, and 3 month follow-ups for the outcome measure. So looking at long-ish term study, I'd be curious to see a little bit longer overall because 3 months is relatively short. if you ask me. I typically want 6 months at a minimum, probably 12 months. All right, so then they randomized manipulation group. They manipulated the AA joint just below the CT junction. And possibly other areas as well. So that's good. They kind of left it to the therapist to determine what specifically the patient might need. It does make it sort of unstandardized. However, it is more of a true case by case basis then. But it does add a little bit of variability to it. We aren't isolating quite as many variables. That being said, it's kind of hard to do that overall. All right, so okay, good. Mobilization, they perform mobilization of the same things and then possibly other joints, depending on what they found. Okay, so they were just doing one bout of 30-second mobilization. So grade 4 sustained mobilization. I'd be curious if oscillation would have more of an effect. Well, they did do cranial cervical flexion exercises as well. The sample size was 108 patients, or that was their goal, I should say. All right. So what they ended up finding was that the manipulation group had a greater improvement than the mobilization group, which is great. The manipulations are faster. Mobilizations are easier to perform. One of the issues that is present with this study is that the authors and primary researchers, so they talk about they didn't receive any funding for this study. Here we go. Footnote. So competing interests. James Dunning is president of the American Academy of Manipulative Therapy and owns a manipulation group, the Spinal Manipulation Institute. His colleague, Raymond Butts, right there. I know he is faculty for it as well. Looks like Thomas Peralt and Faris Morad also are on the faculty there. Now, that's not to say that you can't have a good study by any means. I'd say it's just kind of something that should make you aware. And I'd be curious to see more studies of the same design, but performed by someone that did not have a financial incentive to try and build up the reputation of a manual therapy group. So, maybe someone who's based out of an institution could do a study like this. Not to say, again, that this is meaningless by any means. In fact, you could argue that they might have some more impressive training and background for doing studies like this, or maybe they want to do some research on the outcomes of like fellowship trained versus residency trained versus specialist credentialed versus no credentialing. It would just be interesting to see that variation. But I think this study is a good starting point to show that manipulation absolutely can have an effect, and maybe more advantageous than mobilization. But in my opinion, a little more follow-up should be done as well. Well, be sure to let us know what you guys think about the study, how your skills are going with some of the hands-on stuff. And yeah, thanks for tuning in.